You're very welcome to the University of Warwick MSc in Diabetes Care Information Briefing session. We're delighted to have you here today and thank you for joining us. The running order for today is that we will be giving you a presentation or an overview of the course curriculum and the pricing structure and the online learning environment and just what it's like to study on the programme. And we will also be giving you a guest lecture from one of our local experts and tutors in Malaysia, Dr. Lechman Ramanathan, and he is here with us today. And it will be just an overview or a sample lecture and essentially the most up-to-date information on diabetes care and diabetes management in Malaysia today. So is Lechman on the call just yet?
He's not on yet. He'll be on shortly, Rebecca.
No problem. So what we'll do for the running order, I'll start with the overview of the programme and then we'll complete with Dr. Lechman's sample presentation for you. As I said, you're very welcome to ask any questions or queries that you have in the chat button on the bottom of the screen. So please do so. We'd be delighted to answer any of those queries. So I'm just going to share screen now. Now, can we see that?
Yep, perfect.
Great, super. So this is the University of Warwick and the IHEED Postgraduate Diploma and Master of Science in Diabetes Care. You heard me use the word IHEED, and if you have any interaction with us in the past, you will have heard IHEED and the University of Warwick titles used intermittently and together. So who are IHEED and how do we relate to the University of Warwick? We're actually an online program management company. We are an Irish organisation and we serve governments and ministries and healthcare ministries across the globe, and we specialise in online medical education. Some online program management companies, they would deliver anything from engineering to business, but we are very specialized and we are online medical education only. We're formed and founded by a GP, an Irish GP, and half of our staff are medics. So we're delighted to be founded by doctors, for doctors and healthcare clinicians. So we know exactly the needs and the challenges that you face. We have a strong focus on primary care, but in recent times, our enrollments have shifted. And now, for example, on this MSc in diabetes care, we have both primary, secondary and tertiary care staff, anyone from endocrinologists, cardiologists, pharmacists, dietitians, diabetes nurses. So there's a huge mix and we pride ourselves in interprofessional education. We believe the best way to combat any NCD is the upskilling of the full multidisciplinary team together, which gives a deeper appreciation for each person's role and very essential role in combating NCDs, particularly in the community. We have on our platform, IHEED has over 300,000 course completions and over 30,000 clinicians registered. So you may not have heard about us, but we do have a very large global footprint. And we have a wonderful relationship with the Ministry of Health in Malaysia. And we are partners with RUMC, which is in Penang. That's the RCSI, the Royal College of Surgeons of Ireland, and University College Dublin Medical School in Penang, offering a blended learning family medicine program there in Malaysia, and that is in partnership with the Ministry of Health in Malaysia. And we have a wonderful relationship also with the Malaysian Medical Association, who are our partners locally. So the University of Warwick. The University of Warwick is a top 10 United Kingdom university. It's ranked 62nd in the world under the QS rankings. We have over 14,000 clinicians who have graduated on our diabetes programs in the last decade. The University of Warwick is a member of the Russell Group, and that's really the Ivy League in the United Kingdom and the top research intensive universities in the United Kingdom. And they are, as I said, world leaders in diabetes education and research. And it's very, very important to state here and now that the qualification and certificate you receive is in no ways different as if you flew to the United Kingdom and studied this program face-to-face. Nowhere on your certificate does it say blended learning or distance learning or online. You get the exact same qualification as if you flew to the United Kingdom and studied for 2 years there in person. The only difference is the price, which is a fraction of the cost of actually studying abroad. I put in this slide because I think it's extremely important during this pandemic and this very unusual time that we find ourselves in. This is a map of by Médecins Sans Frontières, and it maps the waves of mortality in a pandemic. First wave, second wave, and third wave is interrupted care on chronic conditions. Over a third of the mortalities globally from COVID-19 have diabetes as one of their comorbidities, and it is proven to be an independent risk factor. So it is never, ever more important to focus on diabetes in particular. I have talked to some diabetes clinicians in the United Kingdom and Ireland, and particularly diabetes nurse specialists who are reaching out remotely to their patients. And they're extremely worried. Glycemic control is not being well managed during the crisis. Diabetes, those living with diabetes are not coming for face-to-face, obviously, interaction. And they are suffering in terms of mental health challenges, and as a result of that there can be a lot of comfort eating, and as a result it just exacerbates their own condition. So it's a very worrying time for interrupted care, particularly in diabetes, and as they're such a high risk group. So it's never more important to look at upskilling in this area. The Postgraduate Diploma and the Master of Science in Diabetes, to give you a brief overview of the structure and the timing. So it's 12 months for the Postgraduate Diploma. And then if you are willing and able and not sick of us and you want to continue, you're very welcome to progress to the Master of Science, which will take an additional 10 months. So it's 22 months in total for both programs. And you must commence with the Postgraduate Diploma. You cannot go directly onto the Master of Science. So one precedes the other. It's developed specifically for the Asia and Middle East regions. And this is very important. We don't cut and paste the exact same curriculum and the exact same cases across every single region that we deliver this program in. We pride ourselves on I suppose, headhunting the very best in terms of diabetes experts locally and internationally. And we deliver, Dr. Lechman, who will be with us today, is a local expert in Malaysia in terms of diabetes management in the community. And it is very important that we combine international expertise with local expertise to make sure we nuance and bespoke the program correctly for you. As I said, international accreditation is the University of Warwick. We're recognised and locally supported in Malaysia by the Malaysian Medical Association and the Ministry of Health. And you will get your full CPD award and recognition from the Malaysian Medical Association. And we're designed and delivered by world-leading diabetes experts. And the whole curriculum is designed around the IDF recommended curriculum. So it is best practice and is mapping those recommendations in terms of best practice curriculum. So this is obviously just a sample. This is not an exhaustive list, but some of the tutors that you will be training you and teaching you during the program is Dr. Colin Kenny, who's a program director, and he's Royal College of General Practitioners examiner and the past chair of the Primary Care Diabetes Society. Dr. Lechman, who will be with us today, is lead in our Malaysian faculty and a senior consultant physician at IPO Hospital. Katie Reid, she is a nurse and she is a University of Manchester professor and a clinical education expert and an expert in patient change, behavioural change in a clinical setting. Dr. Martin Hadley-Brown is clinical professor in the University of Cambridge. He is founding member of the Primary Care Diabetes Society in the United Kingdom, a member of the NICE Type 2 Guidelines Committee in 2008-2010, and a clinical advisor to the Royal College of General Practitioners. And finally, we have Dr. Ralph Odom, who is based in Australia. And he is a clinical professor at the University of Melbourne, and he is also the director of the Primary Care Diabetes Society in Australia. So that gives you immediately a taste of the international feel for this program and how in your own class, not only will you have fellow clinicians from Malaysia, but you will also have a mix of Australian doctors and nurses and pharmacists and healthcare workers and some Japanese. And you will have a wonderful mix in your own time zone or a similar time zone that you will be interacting with throughout the program. So what does the program mean for me? You will always be, even though we take in 300 students onto this program every year, you will really not know that, because you will always be in a very small and intimate group of between 20 and 30 participants. So you get to know your group very, very well. You are never just a number, you are a name to us. We get to know you very well. And our clinicians become very close to each other. They set up WhatsApp groups and chat amongst themselves. And there really is a very strong collegiate feeling to the program. We have 6x6 week modules. They're well paced and flexible. And you have a 2-week break in between each module. And we do break for local holidays. And we're sensitive to local holidays. The personal commitment, we say, and I really should take this out of the slides because it's just not a reality. And loads of clinicians, when they see this, they gasp in horror. It's not the case. Approximately, we would recommend, realistically, it's around 5 hours per week of personal commitment, and might be more leading up to your exams and when you're submitting an essay. But the most important thing is that you attend the webinar, the synchronous live Zoom webinar tutorials that happen every week with your class and your tutor, and the rest is self-paced learning. So just to let you know, I think that's excessive to say 10 to 15. 5 is sufficient to do well on the program. And once, we'll talk about it a little bit more later, but the tutorials, the live tutorials on Zoom every week are also not like what I'm doing today, where I'm just talking at you. They're nothing like that at all. They're very much discursive and peer-to-peer learning, and it's a very nice, open environment where everybody talks and everybody has their camera on, and it's a very warm and interactive experience.
Rebecca,
So
I wonder, would this be a good time to talk to Padma perhaps as an alumni of the program, or and bring in Dr. Lech?
Of course, I'll stop there for a minute.
Yeah, Padma, great to see you again. Just by
Hi,
way of
hi everyone.
By way of introduction, my name is Dermot Brannock. I lead the academic affairs team here at IHEAD. So I work very closely with our tutors, and I work very closely with the University of Warwick, and then get to know a fair number of our students along the way. So Padma, do you want to introduce yourself to everyone here?
Hi, good evening everyone. Oh, maybe I should say good morning, is it?
No, it's good evening. It's everyone here is in Malaysia as well.
Okay. Currently, I'm working in Hospital for Dixon. I'm actually MINT FM program trainee at the moment, FMS trainee program. I completed my diploma in diabetes in April this year, which I joined last year. So I managed to complete it along being trained in the FMS training program. It's a great experience, actually. I would say that. Like Rebecca said, 10 to 15 hours, I would say, is impossible.
Yeah. How did you study at Padma? What structure did you use? Because obviously you have a full-time clinical load, you've lots of other commitments as well as education. How did you juggle everything?
Okay, what I did is actually I spent about six to 7 hours per week. So it's about roughly 1 hour per day. And with the guidance of like our tutorial every week, the one we do every week, that actually helped me a lot because it keeps me on track.
Yeah, and do you find that your care, the way that you're delivering diabetes care has changed now since the program? Because obviously, you came in, you've done the program, you've finished, and you've come out the far side of it intact. But what sort of impact did it have on?
Definitely, it made a lot of difference because, okay, now people, especially our patients, they Google a lot.
Yeah,
they Google absolutely. A lot. They have a lot of information by the time they come to you, actually. So you have to be a step ahead of them when we want to talk to them, I find. Because our knowledge should be better than them when we deal with them.
Yeah.
So,
and how did you find concepts around, lifestyle changes and, you know, the important aspects of kind of behavioral change with diabetes.
Yeah.
Did you get different insights into that, or is it still a big challenge?
Lifestyle modification is always a big challenge actually, because uh, people are working, so it's more of sedentary lifestyle, and they always give us the reason they don't have time, you know, their working hours and all that. So I find it's a challenge, but every single time they come to see us during their visit, their review, I would always emphasize on lifestyle changes first.
Yeah, absolutely. And I think, look, that is the same worldwide. And, you know, even educating people that we had a case study the other evening where a patient was, you know, they were actually very motivated to change their diet, start exercising, and they came back to the next review visit to their family doctor, and they were describing their new healthy diet, which was you know, a nice lot of orange juice followed by granola, followed by lots of fruits, and, you know, what they perceived to be extraordinarily healthy, when you did the carb count on it, was, you know, they may as well have had cake for breakfast.
Yes. And Malaysia being Malaysia, there's a food world actually.
I love the Malaysian food. Padma, the bit that I'm sure many people are going to be slightly apprehensive about, because the average age on this course is, in a given year, late 30s to early 40s. So most people, it's been a long time since they have done any sort of essay writing or real kind of academic stuff. How did you find the getting back into that type of thing?
Actually, I would say the first module is a bit you need to organize yourself and all that.
Yeah.
And when you start the first module, actually there's few short notes you have to do. You get aligned with that. Actually, you do your short notes, you will get tuned into it, how to do it, and the reference and everything will just come in. So as we read and as we go on doing, it'll just come in because it's already there. It's just that we need to brush up.
Yeah, and I think that what you said about the short notes and that, there is a lot of support there, and I think what Rebecca will come on to in a while in terms of pass rates and things like that would indicate, you know, it's definitely not something to be afraid of in that regard. You know, there's a ton of support there, but yeah, it's something that you ease yourself in. And I think the point you made earlier, Padma, about just having a bit of structure and being able to plan your week is really essential. Is there any advice you'd give someone thinking of coming onto the program, as someone who's come out the far side?
Go for it. You can do it. Definitely, you can do it.
Brilliant. Look, I'll just let you man. Are you there? I can see your logo, but not your face.
Yeah, I'm here.
Hey, how you doing? Great to see you.
I'm good. Thank you. Good to see you all.
I was thinking, will at this point, would it be good? Will we hand over to you to do your presentation now? Is that okay?
Sure. I will do that.
Padma, thank you so much for that contribution.
Problem.
It's always good when people are considering this type of thing to hear from somebody that's been through it and survived.
So
thank you so much.
Thanks so much, Padma.
So shall I start?
Yeah, go for it. Absolutely. You should be.
I thought I'll do is I'll just give a background of the state of diabetes in our country. You already probably have an idea, and that's why you are here. But let's look at it at the actual figures and what we may be able to do to change that scenario to some extent. So I will share with you some slides that I got from the Ministry of Health, from the Non-Communicable Diseases Division, and and a bit about this thing called the chronic care model and how that can be used to make changes locally as well. So I'll share the slides now.
Yeah, perfect. We can see that.
So this is taken from the National Diabetes Registry, and this has been in existence for about the last 10 years, and it has grown to a big registry of all the patients in the Ministry of Health, hospitals, and primary care, mainly primary care clinics. So it'll be a good data to look at what's happening to our patients over the years. We know that the non-communicable diseases, that is cardiovascular disease, diabetes, and other NCDs, respiratory diseases, and hypertension and so on, those, all of that actually contribute to 73% of total deaths in our country. So non-communicable diseases is a big deal. Even in this era of COVID, non-communicable diseases are still a major reason for morbidity and mortality. And if you sort of look at it from a risk factors point of view, which is contributing to the deaths, the highest among both males and females is high blood pressure, followed by tobacco smoking, especially in the males. And then diabetes is the third. The next is high cholesterol, overweight, and physical inactivity. This, you would have seen the slide over and over again, that over the years, as we do our National Morbidity and Mortality Survey, the rate of diabetes in our country is getting more, and even the latest 2020 has gone over 20%. So even though this problem has been highlighted, but the prevalence rate is getting more. And it's expensive. Diabetic costs accounts for about 16% of the national healthcare budget. In 2010, an estimated 2.4 billion was spent on diabetes-related healthcare, and I'm sure it's more now. And because of that, we are among the top 10 countries in the world that spend a lot on diabetes. So coming back to the registry, you see by 2017, this is the almost 1.4 million people were on the registry. So this is the mean HbA1c levels by states over the years. And you can see that we are around the region of 8, and it's not really getting better, even though some states are better than others, but generally we are about the same over the years. And this is the percentage of the patients on the registry who reached a HbA1c of target of less than 6.5, and most of them is less than 30%. Okay, in fact, some are as low as only 20%. And this is something that we need to do something about, because A1C actually has a good correlation with the degree of complications later in life. And that, the reason we treat diabetes is to avoid the complications. Then this is looking at the steps that are done in the clinic visits in when the patients come for the diabetic clinic. And you can see that we are doing not too bad, like for example, in taking the blood pressure, taking the weight, and calculating the BMR, we're not too bad. But in terms of examining the eyes, for example, which needs a fundal camera, it's not so good because of the availability, even though it's getting better now, but there is a limit because patients have to go to certain clinics. And then we will also be talking in the course, how can you improve the fundoscopy examinations of your patients, for example. Because doing the blood test, we're not too bad in terms of achieving the once a year target. So this is looking at the targets reached among our patients. earlier I showed you that we're not doing very well in HbA1c. The blood pressure is not also very good. So even though we have the drugs and we are measuring it, we are not reaching the targets. This is what this slide shows, and hence the complication rates are not fully controlled. This is looking at the actual complications, whether they're present or not in our patients. And you can see that in primary care itself, about 1.4% of them already have a stroke. This is in primary care. If you look at it in the secondary care and tertiary care, it will even be more. And looking at the retinopathy, for 9.6 already have retinopathy. And these are something that you know can be prevented. With regards to retinopathy, as much as 11.5% have it in primary care. Diabetic foot ulcers, 1.3. In 1996, of the population of diabetics, almost 4.3% patients already had a lower limb, either digit or limb amputation in diabetic patients. This is that was in the population, but when you look at only in the primary care, this is 0.7. So 30 years ago, the way we were managing diabetes, patients tend to present late, and then we are always catching up on targets. We only had metformin, dinyl, and 2 types of insulin, and managed by one particular doctor, and then they refer when the complications arise, usually when it's too late. Currently, we are advocating that patients should be screened early, and once diagnosed, we need to keep them below targets. And there are now many oral as well as insulin different types of injectable drugs available, and hence the choices and ways to control a patient are wide, and this would be actually dealt with in detail during the course. And we also talk about the value of multidisciplinary team taking care of the patient while it's still patient-centered. Multidisciplinary, but there's one person responsible, and that would probably be the primary care physician. So again, I repeat it, multidisciplinary care, but patient-centered, taken care by one particular person, and most probably would be the primary care doctor. So in that context, I'd like to introduce a thing called the chronic care model, which you also will do in detail during the course, where it refers to ways to improve care in patients with chronic diseases, one of it, which is diabetes. And the first point here is that one feature of it is to improve the skills of the healthcare professionals. And I believe that you see the need, and that's why you're here today to see whether this will be suitable for you. Then you have to find ways to work in teams, because then your output is better, and strategies to educate and support patients, and to have health information systems. Many of you may already have online systems, and that can alert you when some targets are not met, alert you when a patient is due for a foot care examination or an eye examination. And if you have support, somehow a support among yourselves or with other nearby hospitals, then you can have this support mechanism on what to do for a difficult patient. So does it work? So this is a paper which was done actually locally in patients with hypertension. You're wondering whether this chronic care model will make a difference. The study was called COFIS study. It was done among GPs in KL about 10 years ago, if I'm not mistaken, and it's published in 2013. So what they saw that with this chronic care model, there was a better BP control achieved, and it was significant in the COFIS arm compared to the control arm, which is a normal care. So it does work. Sorry. Okay. Then there was another paper about 2 years ago to see the feasibility of implementing chronic care model in the Malaysian public primary care setting. And this was by a group of researchers, primary care researchers led by UITM. And what they found was that it is feasible in our setting, and it's probably, if with good training and commitment, there can be improvement in care, of chronic diseases. So I will end here. If there are any questions, I'll be happy to answer them.
Lech, that was fascinating as always, and I think you're really showing the degree to which there is a significant burden of diabetes, but early intervention in primary care can have a very significant positive impact, on the patient, on their outcomes, and I think the avoidance of complications, which certainly in the UK or Ireland, we look at it on a patient care basis, but you also look at it on the economics of the expense to the health system of a lower limb amputation, or so there's so many drivers to suggest why early intervention and really focusing on the patient is the way to go. The microphones are off for everyone, just because the amount of people on the call, but if people want to ask questions over chat while Rebecca talks through the program structure, you're very welcome. With the recording and the slides that have been used will be available to you afterwards as well. But no, I think in terms of setting the scene as to the need for greater expertise in diabetes, particularly within primary care, I think that was a wonderful overview. And of course, you would have a lot more of Dr. Lechman on the program. So no, it was great to see you, Lech. I don't know if you want to hang on, or if you've got other things to do, feel free to pop off. But thank you so much for that.
Thank you, Dr. Lechman. You're wonderful. That was great. So there's been a number of participants on the webinar asking for the program structure and the tuition fees. Of course, we're going to cover that now, the most important subjects of all. So just looking at the curriculum first, we have 6 modules in the postgraduate diploma. The first module is core principles of diabetes. Obviously, we look at screening, diagnosis, prevention, diabetes prevention, early detection, epidemiology. It's just so much. It's so important, not just for the individual patient outcomes, for even Ministry of Health budgets, that we look very seriously at prevention and early intervention. And I suppose patient education and health literacy. And one of our participants was talking about, just health literacy and education on the school going age. For example, obviously a foot lower limb amputation in the Irish system would cost around €1,000 to the hospital per night for that individual, that person living with diabetes with an LLA, to stay in the hospital. And they would stay in for on average 20 nights. In Malaysian ringgit, that's 100,000 Malaysian ringgit for that one case. And that is so preventable. It does not have to go to such extremes for the individual and for the healthcare system. And the average life expectancy after a lower limb amputation is 3 years. So those type of situations are very, very severe. And it's all about education and patient literacy. So as I said, the first module is all epidemiology, screening, and getting your students on the national disease, or your patients on the national disease register. Next, we move on to the second module, which is treatment. This is quite an intensive module. And Dr. Lechman, of course, covered this in some detail already. And once upon a time, there was metformin and lifestyle change as your go-to treatment for a patient living with diabetes. But nowadays it is, there's so many injectables and orals. There's such a huge array in terms of stepwise intensification and first line, second line, and it changes all the time. And obviously there's new guidelines coming out and new drug trials. So it's quite a complex area now to navigate, particularly with comorbidities and multimorbidities. And I think, very simply put, the moral of the story is that one size does not fit all. And if there is nephropathy, and if there's underlying complications, you really have to adjust your medications and your treatments according to the individual and have a very personalized, individualized case approach and treatment for every single person and patient that enters into your clinic. In the treatments, we also look at, like, in extreme circumstances, at bariatric surgery. We have associated with the program in the University of Warwick a bariatric surgeon who is the head of the United Kingdom Obesity Society. And we also look at diabetes in children and adolescents in the second module. In the third module, this is one that the participants on the program really do enjoy, and they say that they implement their learnings from this module very quickly into their clinical practice. It's very much around the concept, like the NHS has this motto of no decision about me. It's about patient literacy and education. There's 8,800 hours in the year, and you may only spend 3 or 4 hours with your patient. So they have such a long amount of time to self-manage and to keep their condition at an acceptable level, and their glycemic index. There's so much you can do in terms of motivational interviewing that we teach you to do, to educate your patient to take responsibility for their own condition and to improve their patient outcomes. So that's one that the clinicians thoroughly enjoy on the program. Next, of course, we move into complications. I've already just touched on LLAs and foot care. But we also look at retinopathy, of course, and there's a full national screening program in Ireland, and I'm sure there's something very similar in Malaysia with regard to free screening for patients living with diabetes, and we'll teach you to interpret those retinopathy scans. And then in the fifth module, we move on to macrovascular complications. Of course, heart disease and CVD is the largest killer in the world, and many of those who have mortality from CVD have diabetes as one of their comorbidities. And finally, we finish off the last module of the postgraduate diploma is special circumstances, and this is nuanced for particular regions. In Malaysia, we would spend a lot of time looking at Ramadan and Hajj and the repercussions of religious fasting for a patient living with diabetes in terms of hypo and hyperglycemia, and how to prepare in advance for a religious fasting season. We also look at gestational diabetes, diabetes in pregnancy and family planning. If you are a patient living with type 2 diabetes in particular, you're 3 times more likely to have mental health challenges. So we teach you how to identify them. And we look at diabetes in later life and aged care, and of course comorbidities and multimorbidities in later life. If you are very eager, you're not sick of your learning and you want to progress, we then have the Master of Science that you can progress onto after the postgraduate diploma. And this segment of the program takes an additional 10 months. So what we do is a traditional Master of Science would be very research centric, which this is, but the output would normally be a dissertation. And the dissertation would be read by you and your supervisor and nobody else really on the planet. And it would sit gathering dust in the university library. This is not what we want to achieve on this program. And our Master of Science reflects the very pragmatic, scenario-based practical approach that we have to education. So for your output, we would like you to create a 4,000 word journal article submission on ADA best practice, and we will teach you how to do that and how to create that article submission with the ambition that you will be a published researcher in diabetes management by the end of the program. And also we ask you to do a conference poster presentation. Obviously conferences at the moment are virtual rather than face-to-face medical conferences, but we do ask you to do a poster presentation as well. So that would be in a virtual environment at the moment. The real benefit of this is that you get to be published and you get to be considered an expert in diabetes in terms of your journal publications, which enhances your own biography and your own CV, But it also gives back to the research community. So it's very circuitous, and the University of Warwick and you as an individual are giving back your learnings to the research community by being published. And it's all about celebrating and sharing our wins so that we can correctly combat NCDs and diabetes in particular. So when you are starting out on your literature review, we get you to choose an idea. You will do a literature review, you do your qualitative and quantitative analysis, your outline design and methodology. You'll develop your research proposal and you'll get approval, your ethics approval. So it's quite a complex process. You'll collect your data, analyze your data, and then write your paper. But we'll guide you all the way through that process. And you will have an hour each week with your, on average, with your own personal supervisor to run through your research proposal and see how it's progressing and make sure you stay on track. So finally, how does the whole program work in an online environment? So we will start the orientation on the 29th of November. The first week is entirely your orientation week, where you'll be taught, many of us, and so don't worry, many of our participants have been years out of formal study. And the average age on the program is clinicians in their 40s. But in Malaysia in particular, we have a number of doctors in their 70s. And we have younger doctors as well. So it varies hugely. But many of you will have been out of formal education for a long time. So please don't worry. In that orientation week, we really handhold you through how to do correct referencing and correctly write in terms of your essays and you're referencing and looking at in terms of the online formularies and the online library that we have on the system, making sure you reference correctly. And we give you an overview of each module and what to expect in each module. We give you a big help and assistance and hand holding and getting you familiar with the online learning environment. And so you're ready to rock on the following week when you commence the program. So next we have, in terms of how the week works for you, you have your weekly discussion forum. So the tutor will throw out a topic which will cover your learning outcomes for that week. It's usually a scenario-based or case-based approach. So you have an individual with HbA1c and particular blood pressure, particular comorbidities, and you're asked to, what would you do and how you would handle this case? And the tutor acts as a moderator and not ever as a dictator. So it will be an open discussion on the forum that you will discuss openly, and you will reference and you will link back to your references. And then it culminates in the end of the week with your weekly live tutorial session on Zoom, just like today, but not like today, because it'll be much more discursive, interactive, engaging, and you will be chatting with us and you'll have your camera on. So it's very enjoyable. And once again, it's not about us just talking to you and lecturing at you. It's about you engaging, you speaking up, you giving your clinical challenges in this particular case and how we overcome and what's the best practice in that scenario. We have the continuous assessments and the exams. After each of the modules, you will have a 2,000-word essay that you must submit in your 2-week break in between each module. And then at the end of the semester in your postgraduate diploma, at the end of each semester, you will have your online examinations. They are fully online and online proctoring, so you do not need to go to an exam center to do those exams. So I'm just going to give you a quick snapshot because we won't have time to show you the online learning environment today, but it's extremely palatable, extremely engaging. It's so far removed from that terrible historical distance learning of boring PDFs and downloadable PDFs and talking head videos. We have interactive video, 3D videos, interactive gaming and hot topics and quizzes. And you can easily navigate through quite complex scenarios in a very palatable format, and it's easily digestible. So I have to say, I have worked in the education sector for over 20 years, and I've never seen a learning environment like this. And our patient and our student satisfaction, I suppose the student satisfaction records that we receive back from you in your questionnaires prove that the learning environment is one that our participants are very happy on. This is, as I said, we always use scenario-based learning and a case-based approach when we're teaching you. We do have key opinion leader videos from across the world. This is Dr. Mohammed Farghali in the UAE, and he's in diabetes, very senior in diabetes management in the GCC region. And that's the Zoom video or Zoom tutorial that you will have every week for 1 hour. And it's always put at a time that's most suitable for the clinicians. In Dermot, in Malaysia, it's on a Wednesday or Thursday evening.
Yeah, so it's on a Thursday evening around 8 o'clock Malaysian time is the norm. Some could have half 7, 8 o'clock, depending on the specific group. But the flow of that makes a lot of sense in that the discussion forum goes live on a Sunday, and you immerse yourself in that discussion and you read through the online content in your own time, and then you come together with your tutor at the end of the week, and that really brings it to life. And that's, it's case examples, it's it's the interesting complex cases or the red flags, and it's really bringing your experience and a tutor's experience together. And I think what Lechman and Rebecca and I would all emphasize is it's not a lecture at you. It's very much a two-way dialogue between a group of students and the tutor, which it makes it a lot more interesting for everyone.
And please don't worry if you do miss the tutorial. We do record them all, so you can watch it at a later date if you don't manage to make the tutorial. I will very clearly stipulate, though, that those that participate and have a higher participation rate in the tutorials and the forums do, of course, get better results. So what you put in is what you get out. So I just look at this slide here in terms of, this is essentially the confidence levels of the clinicians on our program before and after the postgraduate diploma. So you can see the before is in the purple and the green is the after. So you'll see everything from prescribing CVD prevention in type 2 diabetes, initiating GLP-1 agonists, recognizing emotional distress in the young adult with type 1 diabetes. The difference in the before and after is very, very pronounced. So it's all about confidence in a clinical setting. The next one you'll see here is impact of the program, having interviewed students after 3 years out after completing the program. So there's a huge 80% increase in large positive impact on the quality of patient care. There's some positive impact in terms of the career. So many of our students have gone on to set up their own diabetes clinics. They're recognized as a diabetes expert in their own community. Some of our alumni are sitting at a national level on diabetes steering committees, and therefore creating the diabetes strategy at a national level for their own jurisdiction. And we have some that have gone on to teach in local universities. So we're very proud of what our alumni have achieved to date. And you'll see reputation with colleagues has increased, and also a huge one is the understanding of clinical trial results and research papers. It was hugely enhanced to nearly 90%. So in terms of this administration and support, you will have Dr. Colin Kenny as your program leader. Tutor, for example, Dr. Lechman, who is on with you today, exemplary tutors. Your mentors and supervisors. On every single webinar, you have a member of our team that makes sure you have no technical issues and takes your enrollment, and you get to know very well. And the beauty of online education that is far superior to face-to-face education is analytics. So we can tell if you have failed to engage for a number of weeks, or you haven't been attending tutorials, or haven't had any page views, or haven't been on the learning environment. And we get an automatic red flag, and we can see that if there are any high-risk individuals that may not be progressing too well on the program. And as a result of that, our mentorship team will reach out to you to make sure you're okay, and make sure that there isn't anything personally challenging, and that we can help you via extenuating circumstances to make sure that you stay on the program and you stay engaged and feel like you can catch up. So that's very, very important to us. We have a course management team. Technical support are hugely underused because the system just works so well. So we're very proud of that. And you get a lot, as I said, of individual support. You are not left isolated to study in a distance environment. You're very much considered part of the team in a collegiate environment. There's a lot of touch points, a lot of hand holding with your online face-to-face tutorial every week, and the forums, and interacting with your tutor and your mentors. You really do feel part of a team and part of a group and not isolated. So the entry requirements for the program, we look for not necessarily evidence of proficiency in English language. Most of that in Malaysia in particular is exemplary and there's no need for it. We do look though for full employment in a medical practice through the duration of the program. We look for a degree transcript copy of your MD, MBBS, nursing, pharmacist qualification. You must have a bachelor qualification in a health-related science degree. You need to give us a 500-word personal statement as your motivation for doing the program, an employer or academic reference to prove that you're in full employment and in good standing, and you need a photographic ID. This can't be a selfie. It must be an official ID, like a driver's license or a passport. And I will say, you might think, oh, it's an online program, they can take as many students as possible. That is simply not the case. We cap the number of students in every location because we are dedicated to giving you strong individual support. So we never take more than 30 students in your region. So if we go above that, we just run out of space. So I cannot emphasize enough that your particular group is over 50% full, more than that now. So if you are interested in applying for this intake, I strongly advise that you get your application and your deposit payment into us as quickly as possible, because the deposit is the way that you secure your place and you're guaranteed not to miss out for this intake. So the most important slide of the whole lot is the program tuition fees. Around the globe, our tuition fee is €7,500, which is 35,000 Malaysian ringgit approximately. Just to be aware, we absolutely always charge in euro, so the ringgit exchange rate can vary. So this is an approximation. But we are so delighted that the Malaysian Medical Association has given us a bursary, and that reduces the price of the program by 11,000 Malaysian ringgit. And it's not just for doctors. They're very generous in that they have extended it to all healthcare workers with a bachelor qualification. So that means that the price to you is €5,000 rather than €7,500, and that will be the equivalent of 23,000 Malaysian ringgit as an approximation. Now, I do understand that's still an awful lot of money. But there are, we've had some of the students that have had loans, and we do provide flexible payment options. So you can pay per semester, or you can pay by monthly installment, which takes a bit of pressure off you at least. And we're happy to talk to you in person about that. We also, if you're working in a hospital setting or a large clinic, we also give significant group discounts if it's a larger group. So as I said, we require a deposit of €500, approximately 2,500 Malaysian ringgit, to secure your space. And you can pay by semester or in monthly payments. But I strongly advise you, if you are interested in coming on the program, that you apply and pay your deposit as quickly as possible, because places are filling. We've over 36 students, our nationalities, on the program. We take in 300 students per annum. There's 88 student engagement, 88%, which is huge and very high for an online learning environment and an online program. We've 100% positive feedback on our program support in our participant questionnaires that we give after each program. And there's a 92% pass rate, and that is not because we are easy markers. That is a testament to the professionalism and dedication of our clinicians on the program. So the summary, it's 12 months for the postgraduate diploma, 22 months for the master's. The next intake is at the end of this month, where orientation begins on the 29th of November. You will get your university certificate for a top 10 United Kingdom university, the University of Warwick. Nowhere on the certificate does it say that it's online, distance or blended learning. And it's developed the program specifically for Malaysia and the Middle East, and you have local case-based scenarios and case studies that you will be looking at. You get your CME recognition from the Malaysian Medical Association and your CPD hours, and we have local endorsement from the Malaysian Medical Association. But maybe I didn't state this as obviously as I should have, but the most important thing about the program is it really is fun. And as you see from Padma there, we have a wonderful collegiate experience. The clinicians get to know each other very well, and they really enjoy the program, and that's the best bit. You can't learn if you're not enjoying it, and we make sure that it's an enjoyable experience for you. So that's it. I'm going to end there. And if you have any questions, we'd be delighted to answer them in chat. But I will say that we will be sending out a recording of this webinar afterwards, so you can review it again. And if at any time, when we send out the recording, on that email, we will also have the link to apply and the link to pay your deposit. But on top of that, and in addition to that, we have a very strong team of education advisors that will be ringing you to talk to you in more detail about the program. They will be ringing you on a local Malaysian number or a UK number, but predominantly a local Malaysian number, to talk you through the program next week and see if you have any other questions and if you want to progress to application. So please expect that phone call next week. So if you have any questions for me, actually, you might even get that phone call tomorrow, just to let you know if the education advisors have you on their list. So thank you.
Rebecca, a couple of questions coming in that some of them privately, some of them publicly, I thought I'd just deal with. One of them is on the letter that you need, and quite a few people will be practice managers already, so technically they won't have an employer to easily go to. So that's fine. You can get another healthcare professional in your practice to write the letter for you. Really, it's just saying to the university that you're a healthcare professional in good standing, be that a nurse, a doctor, a podiatrist, whatever it might be. And that's the other question. There is a tendency sometimes to think that a course like this is only for doctors, and that couldn't be further from the truth. I made a comment in the chat above earlier. The highest performing candidate on the program globally in 2019 and 20 is a pharmacist from Georgetown in Penang. And we have a huge mix of doctors, nurses, pharmacists, dietitians, podiatrists, etc. So, it's definitely open to and designed for the entire multidisciplinary team that manage diabetes. The important bit, I think, is that you have some exposure to patients with diabetes, that you're able to put the course content into context. Another question, can we enter directly to the master's program? So the master's follows the postgraduate diploma modules. So you will always do the 6 postgraduate diploma modules first, and then do the master's for the 8 months after that. So it's a seamless transition. We spend a lot of time on these sessions talking about the 6 modules within the postgraduate diploma, because that's what's going to take up the next year of your life, and what you cover is common to everybody. Whereas when you go on to the masters, it's a very individualized experience, because you will choose a topic that interests you. So that could be the use of diabetes registries in Malaysia. It could be something on the take up of structured education programs among patients. There's an enormous list that you could choose from to focus on, and that becomes then your professional project, and you work on that with your supervisor. So we tend to talk about that. We have an information session tomorrow for our current students that they're coming to the end of their 6 diploma modules, and we expect about half of them will go on to the masters, and about half of them will finish with the diploma. So you flow seamlessly from one to the next is probably the short answer.
I have a question that said privately, but I'm just going to read it out because I think it's important if anybody else has a similar question. So I'm an OBS and gynae registrar and interested in taking this program to set up my own clinic. I won't be able to have my patient caseload during the course for any clinical statistics. I presume that's diabetes patient caseload. So I won't have that. So how do I go about this?
That's fine. So it's more that I imagine if you're an OBS and gynae registrar in Malaysia, you're going to be seeing gestational diabetes cases for sure. there's no clinical supervision component to this program. So it's not that you are required to be treating patients and having cases signed off by somebody or procedures supervised. It's simply that the program is very, very practical in nature. So it's based on the latest evidence of clinical trials and research, but it's very applied. And the way we apply it is in discussion about patient case scenarios. So we would use a case of, here's Brian, he's a 45-year-old male, comes to your clinic, complaining of, a slight ache in his foot when he walks. And, you're into diagnosis and treatment options and what are red flag symptoms. So that's why we ask that people be in a healthcare setting so that they're used to contextualizing patient case scenarios. It's ideal if you're seeing patients with diabetes. It's not necessary if you're not. And bear in mind that a pharmacist is going to have a very different patient case exposure than a podiatrist or a doctor or a nurse. So I wouldn't be concerned about that. And certainly I think if that leads on to something else, that there's a lot of people that do this program while they're in specialist training, be that in family medicine, or be that in emergency medicine or obs and gynae, or we've had some cardiovascular people, so it's perfectly possible to do a postgraduate program while you're doing specialist training. You just really need to be comfortable that you've got that 5 or 6 hours a week, most of which is in your own time, that you can dedicate to study, and that you can come along on the Thursday evening for most of your tutorials. We won't pretend everyone gets to all of them, but it's very possible. Fresh medical graduates, are they allowed to apply? Absolutely. Yeah, absolutely. Fresh medical graduates, fresh any healthcare graduate is eligible to apply, no problem. So someone's coming in, requirements for the program. So to sum up the requirements, it's a health science degree. We will then ask you to give us a short personal statement and to give us a letter from an employer, which can be a colleague if needed, or an academic, to say that you're a professional in good standing, and then photo ID, and you upload all of those through the platform. It's a really simple process, and the education advisors, they will be walking you through all of this anyway. So there's a whole, I think the common thread throughout this is there's a whole team to support you. Okay, other questions coming in?
The cost, sorry, I suppose I spent a lot of time just talking about the cost of the postgraduate diploma there. So the postgraduate diploma is €5,000, which is 23,000 Malaysian ringgit approximately. If you wish to progress to the Master of Science after the postgraduate diploma, it is an additional €4,500, which is an additional 21,000 Malaysian ringgit. Yeah. So the postgraduate diploma is 23,000, and then the master's is 21,000.
And the second part to that question there, the postgraduate diploma is compulsory prior to the master. So you do the postgraduate diploma first, and then you seamlessly go into the master's after that if you want to. Riz, that'll be a very individual conversation, Riz. So we'll have one of the advisors have a chat with you about that.
Yeah, we've gone over time, guys, and I realize you're all very busy clinicians, so I don't want to spend too much time with you. What I will say is you will get a recording of this event and of this webinar, and you will get in an email with the application link and the deposit link. So we urge you to apply without delay if you are interested in progressing for this particular intake. And our education advisors will be calling you by phone within the next week. So look forward to that call, and we hope to see you on the program in November, December.
Thank you very much, everyone.
Thank you so much for your time.
Enjoy the rest of your evening.